Hello, everyone, and welcome to a new episode of Majlis podcast by Emirates Hospital Group. I am Wael Berro, your host for today, and I'm a family medicine consultant at Emirates Specialty Hospital. Today, we've decided to cover the whole topics of gynecology and obstetrics in 10 minutes. And who's better to do that than Dr. Sabiha? Dr. Sabiha?
Hi, Dr. Wael Berro. That's a very kind introduction. I'm Dr. Sabiha Banerjee, obstetrician and gynecologist. I've been in this field for 26 years. Yeah, and I've also been a teacher. I'm an ex-associate professor from India, taught in a medical college. I'm a clinician and surgeon at heart.
It's a pleasure having you here, and welcome to the group as well. I understand you're at Motor City, and I'm sure with your expertise today, we're going to give the best kind of advice to our audience. So I'm going to divide today's talk into two parts because I know we have a lot to cover, but we want to try to give as much information as possible to the audience. Let's talk about pregnancy. People always think of pregnancy as the act of getting pregnant, then they come to the doctor and then they start getting checked. But pregnancy is really multifactorial and much more complicated. It starts way before you get pregnant. How do you address that? How do you approach, and what advice do we have for our audience?
So, Dr. Wael, I think preconceptional counseling is extremely important here. It's important for the body and mind to be prepared well before you embark on this beautiful journey. So I would like to advise my patients that there's so much more that can be done at the preconceptional visit. So it's important to set it up, speak to the doctor, get in the right shape, and then get onto the skydive.
Of course. So there's the mental preparation, of course, and then there's also the medical preparation, I assume. Now, from a medical preparation, my understanding, folic acid, but of course, there's much more than that, right?
So yes, it is about knowing the patient's history, what are her risk factors, if something can be corrected before she starts off on this journey. Folic acid supplementation, is there anemia? Is she predisposed to diabetes? Has she had any kind of pregnancy losses before? All this has to be kept in mind.
Of course, very good. Now, one of the things that my teachers used to say, and that used to be a rule in gynecology, that a pregnant woman is not a patient, because this is a normal process. And I think that's very important when you handle the antenatal care, let's call it, which is kind of the care of people who are already pregnant, correct?
Absolutely, absolutely. So I would like my patient who's a mother-to-be to think of it as if she's embarking on a skydive. So there are two ways to get onto this journey. It'll take you to scintillating heights, right? So either you freeze in fright and not enjoy the journey, or you keep your eyes wide open, waiting for the wonders to unfold and see the beautiful view. So basically, it is about looking after your nutrition, exercising right, taking in the right vitamins, making sure that you are well rested, you are maintaining a work-life balance, and you're noticing small signs and symptoms which can swerve this otherwise smooth pregnancy into a risky zone, and reporting it to your doctor.
Of course.
That's important.
Thank you very much. And that's, I'm glad you compared to skydiving, because I've always thanked God that I don't get pregnant, but also for sure I will never skydive. So that's very good. But I hear it from a lot of women who are pregnant where they are probably, and let's call it misconception, and correct me if I'm wrong about it, that a pregnant woman should never take any medication. Even paracetamol, you see them very anxious. So some of them are struggling with back pain, or maybe they're sick and they have a bit of fever and they're worried and they don't want to take any medications. The other one is that, I need to eat for my baby. And I keep saying to my patients, like, no, you have to eat for yourself. Don't worry. The baby is finding his way or her way through your blood and they're getting their nutrition, but you need to nourish yourself. You need to look after yourself. Please, let me.
So that's right. So what happens is that a lot of women are nauseous during pregnancy. Pregnancy can be an immunocompromised state and you can catch flus easily. So it's important to vaccinate yourself. It's important to know that minor headaches, nausea, vomiting can be tided over. It's going to be self-limiting, and it can be helped with medications, and these medications are not going to be harmful. Coming to the point to your question of eating right, it is important to know that in pregnancy, the digestion slows down. So you want to finish your last meal around 7 p.m. in the evening, if that's possible, And it's important to feed yourself with the right ingredients. You need that protein, you need that carb, you need those fats, but in what proportion? all that gets expanded when you come and see me in the clinic.
Of course. And just kind of like now, and this is honestly like, this is now becoming the family doctor again. I'm still a doctor, so I need to think as a doctor sometimes. Exercise. I see a lot of women worried that, I shouldn't exercise, I stop exercising. And you just highlighted that the metabolic rate already slows down. So a lot of women start having more back pain and they start gaining more weight because they stopped exercising. What's your take on exercise during pregnancy?
No, it is important to build a healthy neuromuscular connection. It is important that you stretch, that you don't let the muscles be lazy, that you are active and you are taking on the permissible levels of exercises. So again, that depends on what she's used to before and what she can do now.
Fair enough. So the bottom line, enjoy the journey. It's a lovely journey.
That's
and
right.
It's for years to come, I hope. But now we're going to change hats and we're going to say, okay, we're finished obstetrics. Let's do gynecology. Okay. A lot of women, and that's part of the journey of being a woman, they start having uterine bleeding, which is bleeding or cycles, the normal menstrual cycles. But there's something we call in medicine the abnormal uterine bleeding. How do you define that and how do you approach it?
So, doctor, this is one topic where the women are really scared when their cycles go wrong. So, abnormal uterine bleeding is defined as any deviation that happens in terms of frequency. That is, if she's bleeding, her cyclical frequency is 21 to 35 days. If the cycles become shorter or longer, if they last longer than 7 days, or if the amount of bleeding is more than 80 ml. Also, after menopause, if a woman bleeds, it's definitely an abnormal uterine bleeding.
Of course. So age is definitely an important factor here. Let's take the one who's still menstruating. I see a lot of anxiety among women I see at the clinic where is your menstrual cycle regular? And the first thing they said, last cycle was late 3 days. And I see kind of they want some of them, they want it exactly like a German train, let's call it. They want it to arrive on time and last the same duration. Is variation 2 to 3 days normal?
Yes, variation of 2 to 3 days is normal. What is not normal is if the cycle stretches beyond 35 days.
And then you mentioned that if someone is menopausal, then of course that's more serious. What does that mean? I mean, let's say I'm a woman, I'm 55, and suddenly after 5 years of no cycles, I see bleeding. Is it bad news?
So it has to be looked at seriously because postmenopausal bleeding, in most of the cases, may not be a normal phenomena. And she has to be physically examined. Some diagnostics may need to be carried out. And once we reach a conclusion what it is, it could either be just a one-off or it could actually be an endometrial hyperplasia and very rarely even an endometrial cancer.
Fair enough. So it doesn't have to be something serious, but for sure we have to take it seriously. Let's put it this way.
That's right.
Fair enough.
I would also like to mention the highest incidence of abnormal uterine bleeding in terms of a heavy cycle or a prolonged cycle happens between the ages of 40 to 50. And the most common conditions could be myomas or fibroids. It could be adenomyosis. It could be an endometrial polyp. It could be endometrial hyperplasia, or it could just be simply anovulatory cycles. So in order to reach to the crux that what is it that is bothering her, we have to ask certain very important questions. Most of the women I feel get into a situation where they feel very threatened if it is diagnosed with a myoma. But this is where I want to step in and say that there are many questions to be addressed here. What is her age? What is her symptom? Is she feeling pressure? Is she feeling pain? Is there a progressive worsening of her anemia? Is it restricting her daily activities? What is the size of that myoma? Where is it located? What is it doing? And once I have precisely found out what's going on, I know that there can be either a medical management to it or a surgical management to it. A medical management usually is in the form of a progestin-containing intrauterine device, which is also very popularly known as Mirena, or it could be gonadotropin releasing hormone agonists, which are less favorable compared to the Mirena, but still they work, or it could just be an oral progestogen. If, however, the medical therapy fails or she doesn't tolerate the side effects, then again we come back to asking the question that does she become a candidate for myomectomy or is she a candidate for hysterectomy? So depending on her age and her childbearing status, we decide whether she needs a myomectomy or a hysterectomy. The moment we talk about surgery, again, it spirals fear.
Yeah.
But this is where I would be very happy to tell you that in professional hands, it's not a big deal. We have keyhole surgery or laparoscopic surgery. We can also do it by open methods. And in both the cases, there are excellent results. Another thing that I would want to speak about right now here, and what really excites me, is that with the advent of surgical advances, we have something known as V nodes. The V nodes is about going through the vaginal route and accomplishing a surgery, which means vaginal natural orifice transluminal endoscopic surgery. So you go via the vaginal route, you create the tunnel there without the tunnel vision, get in there and remove the uterus through the vaginal route. So it is literally scarless.
Which is basically, exactly, no wound, no healing wound, and all the stitches are internally.
Yes, that's right.
Okay.
That's right.
It's impressive. Medicine keeps evolving, and we as doctors, we have to keep track of this improvement.
Yes.
Now, all the conditions, and this is just to maybe summarize a bit what you're saying, not that you need the summary, but you mentioned few words, the technical ones, the adenomyosis, the myomas. It's very important for the audience to understand that these are benign tumors, because a lot of times I hear people saying, like, I went to my doctor, he or she told me I have a tumor. And I said, well, actually, the word tumor could mean good and bad stuff. So it doesn't mean anything. And you could see a lot of the mental factors. So if someone ends up having surgery, it doesn't mean that it's a bad news. And that's very important for, I think, for audience to know, right?
Absolutely, doctor. So let me, take a granular approach here. For example, if it's a myoma, we know that it is the commonest smooth muscle tumor in women. So there's
benign tumor as well.
And it's benign.
Yeah.
And it's benign. So it's not bad news. If we come to adenomyosis, it is because of estrogen that the condition starts developing, meaning the estrogen is acting on endometrial glands and stroma, which are located within the myometrium and causing a cycle of bleeding.
Yeah.
So if we were to suppress this estrogen with the help of hormones, then the condition can be corrected.
I always say it in my practice and in any meeting that we're not equal. It's not about the gender equality. I think even in illness, we're not equal. So I think in a way what you're summarizing, and this is what I liked what you said about the symptoms, we have to individualize the care for each person.
Absolutely.
I might have adenomyosis, you might have adenomyosis, but if I'm bleeding and I'm symptomatic and I'm anemic, then I might need treatment. If you're not symptomatic, that I discovered yours by chance, then you really don't need to worry, just continue and follow up with your doctor, right?
That's right. That's right. So the follow-up is very important.
Thank you very much. Now we're going to jump to a third one, and this is my favorite subject. Again, I'm a family doctor, so it's all about prevention. It's all about early detection. Does it apply to the field of gynecology? How do we do prevention in gynecology?
I am so glad that you asked this question, and that's my favorite part
Great,
too.
we agree.
So we can start when they are young. So between 10 to 11 years of age, it is recommended that we give the girls and the boys vaccine for HPV. It prevents cervical cancers, oral cancers, penile cancers. Educate them about knowing their body throughout the years that it's going to change. When you teach them young, it's likely to take root. That is number one. Number two, it's actually looking for the clinical diseases. So once she steps into her 40s, a clinical breast examination, mammogram, and breast ultrasound is important. We may need to start even at younger ages, depending on the patient history. And here I would like to elaborate about the use of menopausal hormonal therapy. There have been some studies done in the past which have demonized them. So when a menopausal woman is experiencing symptoms which could be from head to toe, right from a cognitive decline, a brain fog, to insomnia, to palpitations, to accumulation of body and visceral fat, to muscle cramps, to loss of bone, loss of muscle, which is also known as sarcopenia. the symptoms have to be addressed. It could be loss of libido, it could be a dry vagina. And because we have learned from the past, we have a set of designer estrogens, literally, which can help almost every woman. Having said this, it is important that she undergoes a physical exam, goes through the necessary screenings, her risks are stratified, and then we take a fresh look at what can be offered to her at this transformation, which is life-changing.
Absolutely, and I think that's spot on because a lot of women come. Now, I think definitely there's a good trend that with perimenopause and menopausal, and then people are, I feel they're accepting more the hormone replacement compared to 20 years ago. But you're absolutely right. There was this bad stigma around it, and people are afraid because of association with some cancers.
Right.
But again, as you said, it has to be individualized, has to be to each person, and there is a solution, and they're quite safe.
Right. And doctor, when you mention cancers, I would like to say that even cancers are a relative contraindication, because you have something like SERMs. That is, they act on specific receptors. They will beautifully go and bind to receptors in the breast and in the uterus, block them so that the impact doesn't happen there, and then you're clear.
I see. So for everything there is another. For every problem there's a solution if needed.
That's right.
Perfect.
That's right.
Dr. Sabiha, I could keep you here forever. I think this with the topic of obs and gynae is never ending, but it has been a very enlightening meeting today. Any last minute messages would you like to tell our audience today?
So, Dr. Wael, thank you for having me. It was lovely conversing with you. I would like to tell you that my philosophy is very simple. Let's break down and simplify state-of-the-art medicine and bring it to our patients and offer it in their service.
Thank you very much. And this brings end to our episode today. Thank you very much for listening. Stay tuned. We'll be back very soon. Thank you.